Hello, and welcome to this AJMC Peer Exchange, Expanding Treatment Options for Metastatic Breast Cancer. I'm Dr. Hope Rugo from the University of California, San Francisco's Comprehensive Cancer Center. Joining me today in this virtual discussion are my excellent and expert colleagues, Dr. Claudine Isaacs from the Lombardi Comprehensive Cancer Center at Georgetown University, Dr. Priyanka Sharma from the University of Kansas Cancer Center, Dr. Tiffany Traina from Memorial Sloan Kettering Cancer Center, and Dr. John Fox, Vice President of Clinical Transformation at Spectrum Health. We really have great experts on our panel today and are excited to have John Fox as well to give us a different perspective on treatment choices for patients with metastatic breast cancer. Today, we're going to highlight a number of topics pertaining to the systemic treatment for breast cancer and the impact of recent clinical trial data on clinical decision-making. Let's get started on our first topic. Our first topic is treatment after progression on a CDK4/6 inhibitor plus endocrine therapy. One of the big questions that comes up, Tiffany, is whether or not we routinely rebiopsy or reorder molecular testing at progression in patients with hormone receptor positive metastatic breast cancer, and whether or not you actually test and decide on treatment for ESR1 mutation status, and whether if it's positive or negative, you retest in the future because it might impact your treatments. And then, of course, attached to this is what we know now about mechanisms of resistance to CDK4/6 inhibitors. Can you tell us a little bit about those areas?
Sure. I think there's a lot in there to unpack. But to start with, I think that having tissue material for biomarker assessment in the setting of metastatic breast cancer is important. We know in the first-line setting to never assume to recheck your ER, PR, and HER2 status so that we're not missing the opportunity to use appropriate targeted therapy. Together with that, I think in the first-line setting, although we're often using a CDK4/6 inhibitor, it is a nice opportunity to start your molecular testing, I think, for PI3 kinase status, knowing then that you may have an opportunity in later line therapy to use a PI3 kinase inhibitor. So I do find that often in first-line metastatic breast cancer, routinely we're doing a biopsy, sending those hormone receptors again, and beginning the molecular profiling. To your question about ESR1 mutations, many of our women have had an adjuvant aromatase inhibitor, which drives the development of an ESR1 mutation. There's a great rationale for thinking that fulvestrant and SERDs may be better in the setting of an ESR1 mutation. I think often I will use the clinical circumstances to help guide me in what that first line choice may be for an endocrine therapy backbone. And the ESR1 mutation can sometimes guide that.
That's really interesting. I think that that's a question that I think is of interest to everybody treating patients, but would you serially test for ESR1, for example, with ctDNA?
So, it is an option. Over time, we have considered doing cell-free DNA testing, more looking for an actionable mutation like the PI3 kinase alterations. ESR1, in my experience, I haven't seen it crop up in later line endocrine therapy, but it may just be that I haven't seen enough of that. I'd be curious to hear what other people think in that setting.
Yeah, I think, Claudine, do you test serially for ESR1 mutations?
We've tested more for PI3 kinase mutations, but in doing so, we often get the ESR1 mutation as well, but we're starting to do that. I think the other question is, what is the difference in ctDNA versus tumor biopsy, and might you be seeing differences between those? So we've had a few patients, who are trying to be on top of things and say, okay, looking forward to the next thing, I'm on a CDK4/6 inhibitor. Do I have a PI3 kinase mutation? And some of what we've heard is that, the optimal time to test is when somebody really has disease progression and not while they're having quiescent, while they're having a response to the treatment they're currently on. So I'd also be interested in how people think about doing this, because yes, we like to be organized and be thinking ahead, but at the same time, testing while somebody is responding to their current treatment might not be the best time to do it.
Yeah, although I think
that's a great point.
Yeah, I think it is a good point. I think that, we've seen that ESR1 mutations come and go, and we may not even getting a very accurate representation of what's going on. So I don't serially test myself, but I could see a situation where you might. But also, it does appear that PIK3CA mutations are conserved, so that you gain a few in the metastatic setting and with progression, but not a lot, so that you could probably safely test while you're doing treatment. But I usually test when they're starting to look like they might be
Right.
progressing sometime in the near future.